Very, hello, am I audible, right?
Yes.
Happy World Physiotherapy Day to all of you. And here we are gathered on the virtual platform for the topic of role of physiotherapy in ankylosing spondylitis. Our resource person is Dr. Ratan Kumar, and we are now we are live on YouTube. So over to you, Vaibhav ma'am.
Okay, so happy World Physiotherapy Day to all. So dear participants and respected panelists, with a great pleasure, I would like to introduce our keynote speaker of today's webinar, that is on role of physiotherapy in ankylosing spondylosis, Dr. Ratan Kumar sir. Dr. Ratan Kumar sir is working as an assistant professor at Ashok and Rita Patel Institute of Physiotherapy, a constituent of Charusat University. Sir is well known in the professional in the field of physiotherapy. Dr. Ratan Kumar sir's dedication to the advancement of physiotherapy is evident by his academic as well as research achievements. With a record of more than 18 publications to his name, sir has not only contributed to an academic but as well academic and research part, but sir has also provided insight into a critical role of physiotherapist in the overall healthcare ecosystem. So we are fortunate enough to have sir with us to share his profound knowledge and expertise in the field of physiotherapy on a particular topic, that is ankylosing spondylosis. So which is a condition in which even patient and healthcare provider has unique challenges. So to address that, to manage the condition and how to improve the overall lifestyle of a person, sir is going to focus on that. So sir is a perfect speaker for today's webinar. So we welcome you, sir. On the other hand, I would also like to mention that this webinar is organized by IAPWC KEDA team on the occasion of World Physiotherapy Day. So in a celebration of this World Physiotherapy Day 2023 under the theme of different inflammatory arthritis. So without causing any further delay, I would like to introduce sir, and let's warmly welcome sir on this virtual platform. So we welcome you, sir. Also, I would like to add one more point for the participants, that is, if you have any query or doubt, please leave a comment. So we are going to have question answer session at the end of the webinar. So we'll address your queries at the end. So sir, over to you. We are looking forward for your valuable insight into today's webinar.
Thank you, Vaibhav ma'am. Am I audible, right?
Yes, sir.
Yes, sir.
Yeah. Before I start my session, I would like to take this opportunity to thank IAP Women's Healthcare Brands for giving me this opportunity to share my thoughts or the insights about the condition, what is supposed to be. For the audience, I have been informed that it will be a mixture of student, clinician, and professional. So I'll be trying to go the content in such a way that some of the foundation or some of the clinical information which are required for us to deal with in terms of the process of assessment and diagnosis and management. That is how I am planning to go through. So yeah, let me start with the statement that this is one of the very frequent line we used to see in the textbooks and some other articles also. So I would like to ask to audience that what is the disease that improves pain and stiffness with the exercise and worsen with rest? So this is a common line or tagline you can say, particularly defining this particular condition. So you already know that I'll be speaking on the ankylosing spondylosis. These are many synonyms are available for the ankylosing spondylosis. So some may call differently, but they are synonyms of one another. So no need to confuse about the synonyms. Like I said, I'll be covering some of the introductory portion, etiology, then clinical characteristic of this condition, and what are the radiological features we can look into, and what are the diagnostic criteria, because we'll be involving in some diagnostic process also. And what are the lab tests we may expect when patient comes to us, or we may advise or recommend the patient to go to have for lab test. And how do we go through the differential diagnosis process, and what is the probable diagnosis of this condition, and what are the options available for management of this condition. And at the end, I will be mentioning some of the well-known person or personality who are already diagnosed with this condition. We have already known that ankylosing spondylitis is one of the Greek words coming from ankylose fusion and spondylitis inflammation of the vertebra. So it is a seronegative progressive inflammatory disease presenting with the pain and stiffness in the axial skeleton, specifically starting from sacroiliac joint and spreading to the spine. So spine, latter part of the disease may even spread to the peripheral joints also. And we have started looking this condition from our clinical practice, but for our knowledge, this is not a new condition. This is first reported in 1666, okay, by the Irish physician. So this is not a new condition. This is one of the old conditions we physio frequently encounter in our OPD or our routine. The condition is affected among the adolescent young adults who are aged between 15 to 40 years of men. And incident rate is 0.6% of adults. And people who have family relatives with the AS, they have occurrence of 30 times more compared to any other people who don't have any hereditary issues. So more or less, this is something to do with the hereditary influence also. One of the typical tissue types is presence of abnormal XLA-B27 tissue type. So those people who have this kind of abnormal tissue types, 95% of the case they have diagnosed positively. Many people, all of us may not be at risk of this condition. The person or the people, group of people who have positive XLA-B27 markers, and those who have a family history of AS and frequent GI infection. So these are proposed to be group of people who are at risk. Many of us maybe wondered that how come this GIT infection is leading to joint problems and all. This is still trying to prove, and based on the literature, this is one of the risk factors we have already come across. Clinical characteristics can be broadly classified into two particular ways. One would be the features which we see related to the articulars or nearby or articular or periarticular tissues. And another group of features would be extra-articular features. By the name suggests, articular features are the features which will be seen within and around the joint itself. So most of the time, these features are insidious in oftenly, and they frequently complain morning stiffness, which are typically in the early stage of disease. One of the hallmark deformity, what you can see in the advanced stage of disease, this question mark deformity. This particular pattern of deformity may not be able to see in the early part of the stage, but as the disease progress or advance, the overall deformity will be pushing towards the question mark deformity. Typically, to the lumbar spine, you may find pain and stiffness. Then, in response to inflammation, we'll be able to see spasm around the paraspinal muscles. And this will be both bilateral, right? It will not be only one-sided, it will be both sides, ranging from sacroiliac up to the lower thorax region, or sometimes it may extend up to the mid-thorax spasm pattern. And lumbar spine, all the movements pattern will be restricted. So sagittal and frontal plane movement will be typically restricted, and all the movements are affected. Coming to the features related to the thoracic, it reduces the costovertebral and the costovertebral movement. So we all know that these two joints are very crucial for our rib cage movement. So when this movement in these two joints are restricted, ultimately they are going to reduce the mobility of the rib cage, and eventually it is going to affect the lung function, and later on it may create like a restricted lung disease, which can be seen in the later part of the disease, may not be in the early case. As these two joints are restricted or reduced in their mobility, the chest expansion is becoming restricted. So this is also one of the typical features, or one of the strong features we'll be looking for when we come to the assessment portion. I'll try to elaborate this one. And because of this restriction, the individual start depending on the diaphragm for their respiration, not the normal movement of the rib cage. So that become another pattern of respiration what we used to see among the people. As I said, as the condition is progressed, apart from the exoskeletal, it will also start spreading the features to the peripheral joints. So the most common joints which would be the early or else the beginning part of the progression could be seen in the shoulder, hip, and knee joint also. So if it is spread in those peripheral joints, then pain and stiffness of those particular joints also could be seen as the disease is progress. Why I am putting this emphasis is because the condition is going to be keep progressing. It is not going to be a static one, or it is not going to be a reversible one. So we need to know that in the beginning where they are starting and how they are progressing in terms of features. This also need to be understood. Here, the pictorial presentation, what I'm reporting here is about the extra-articular features, which is affected apart from the joints. So it will affect the eye, it will affect the heart, the GI, the tactiles, lungs, kidneys, skins, and so on. And again, the most challenging part, what we will be frequently dealing will be the osteoporosis or osteopenia. This all are extra-articular features frequently we used to see among the people who diagnosed with ankylosing spondylitis. Once again, these extra-articular features may not be seen in the early stage. All of them may not be available or present in one individual, but any combination of individual can be seen. Here, I would like to point out some of the 9 most significant physical problems the people who diagnose with the ASR encounters. They have difficulty sleeping on the ground line, or I would say in the simpler ways from many people who already have a habit of sleeping on their tummy or stomach, they'll have much problem in doing that. They have stiffness on waking up. Early morning stiffness is one of the key complaints, most of them complaints. Difficulty in prolonged standing or prolonged sitting, or else you can say that maintaining a sustained position, either in the sitting or standing, become one of the more common difficulty for them. And bending forward to pick up something or to do some household related or daily routine activity related become another difficulty for them. So this group of people, they prefer to be spectator rather than participating in the activity. Like I said, the early onset early diagnosis could be around 15 years and above. So this is the age where most of the adolescents and young adults, they should involve in physical activity like playing sports and recreational activity. So you may start observing that this group of adolescent or young age people, they prefer to be spectator rather than actively participating in the physical activity. Their pain increase with a high level of stress. So this stress is what I am relating is the mental stress. Whenever their mental stress increases, their pain and other features also keep increasing. They get easily tired. In short, they cannot go for any prolonged activities, like it could be occupation related or household related or any personal activity related. So they get easily tired with their activities. And they have limitation in their leisure activity, leisure and sporting activity. So these are the 9 most significant problems of most of the ASP individuals encounters in their life after the disease attack. I'd like to highlight some of the radiological features. Many of us may be thinking that why we should focus on radiology, because we are not going to deal with the radiology. Because radiological features are one of the key criteria for diagnosing the condition. Here we are not comparing with the concepts or knowledge of the radiologist, but at least the basic changes which we could see in the condition should be aware. So normally, like I have mentioned, the condition generally started with a side joint or sacroiliitis. So in that case, when you will take the when you get the X-ray of the SI area, you may find erosion or sclerosis, and that is in the advanced phase. And when the condition becomes advanced, you may even find ankylosing or fusion of the SI joint. And in the spinal joints, this is starting from lumbar to the cervical region. Epiphyseal joint erosion can be seen. The squaring of vertebral bodies can be seen. This is completely contrasting with the osteoarthritis. Osteoarthritis means to say squaring of the hourglass appearance is normally found in the advanced stage of the osteoarthritis of the spine. But here you can see the squaring of the vertebra, not lipping, not tipping. Okay. Ossification of this margin. So this is again one of the things which we normally don't see in the beginning phase, but when it enters to the mid phase or in the advanced phase, it has become very remarkable. Syndesmophyte is nothing but the calcification of ligaments and periarticular tissue around the joint. They become calcified. Like I said, again, in the beginning phase, it will not be quite evident, but if you are good image reader, then only you can identify it. But obviously, when the disease progress, the amount of syndesmophyte is going to be very prominent. And this may start from the lumbar region and gradually extend to the thoracic as well as to the cervical region. When the syndesmophyte are mature enough, at the end, you may look like a bamboo spine, where all the intersegment of the vertebral bodies are fused or merged together with the syndesmophyte. At the time we could see the hallmark features of the radiology bamboo spine can be evident at that time. So this is some example of X-ray. X-ray is the first line of investigation in this condition. People may advise for a CT and MRI, but it may not be relevant if you are dealing or if you're concerned only for diagnosing the condition. So X-ray, plain X-ray, or conventional X-ray is good enough to give relevant information to bring up to the diagnosis. If someone has some other complications, by the time only they may refer or advise for CT or MRI based on their requirement. If any neurological or some other features involvement that can happen in case of fractures along with the ankylosing. So that in those situations, or any nerve entrapment or any radiating situation arises, the time higher resolutions like CT and MRI could be advised. Otherwise, just for understanding or just to diagnose the condition, plain X-ray or conventional X-ray is good enough, sufficient enough, no need to go for higher resolution. We have different evolution of diagnostic criteria. The first one was formed in the 60s, the Rome criteria by Telegram. And later on in the late 60s, we got another criteria that is Neo criteria. And in the later part of the 80s, we got the most recent one, modified Neo criteria. This is the one which we currently in practice. Other one, it is there, but it is not in practice. So let us see how modified Neo criteria says about. It talks about two criterion. It focuses on the clinical criterion and the radiological criterion. These criterions are used to diagnose the condition, and this will be one of the simplest form of diagnosing any AS condition. And based on this one, later on, people may get information from the laboratory investigation or some other condition-specific outcome measures. So in the clinical criterions, 3 points are there. They'll be having low back pain and stiffness, which is more than or equal to 3 months, which are improved by exercise and not relieved by a rest. This is one of the hallmark features I've been mentioning earlier also. They'll be having limitation of lumbar spine in the sagittal and frontal planes. So flexion, extension, and side movements should be restricted, and limitation of the cells expansion compared to the normative value which are associated with the age and gender. These are the 3 points we need to consider when we talk about clinical criteria. Now, coming to the radiological criteria, the SI joint involvement is one key component here. Because, as I have mentioned earlier, the condition normally started from the SI joint. Very rarely it may start from other lumbar or some other joint, but most of the time it will start from sacroiliac joint. So if it is only one-sided, then at least grade 3 has to be there. And if it is bilateral, then at least 2 grade has to be there to confine them or to diagnose them as well as. So overall, if someone has a unilateral radiological grade 3 or 4 or bilateral grade 2 or 4 sacroiliitis and presence of any one clinical criteria out of these 3 which I have mentioned earlier in the above, that will be termed as a definite age. Okay, so this is the simplest way to screen. You can use this one for screening also, and just to communicate with the other professionals who involved in the management of ASLs. I find that this is one of the easiest way, easy criteria to practice use in clinical practice. Diagnosis process, once you get that definite AS is there, some of the evidence also we need to gather just to see that how the disease goes on. So like I mentioned, the lab investigation also will be required. ESR and CRPBs are some of the tests which will rule out the involvement of inflammatory situations or not. Blood counts to identify any systemic involvement or not. And it's still be 27, like I have said, is 95% of the case is abnormal tissue is present. And based on the suspicious, suspicious of involvement of extraarticular features, n numbers of tests can be performed. So that will be extra beyond the diagnosing process. Radiologically, lumbopelvic and SI has to be taken. The thoracic, cervical, and lumbar, every segment has to be exposed. It should not be exposure only for a SI joint. It has to be covering all spine. If needed in the later part of the disease, just for screening purpose, hip and shoulder, even the knee joint also need to be exposed for screening process. Like vertebral column features, I have already discussed earlier also. And yeah, involvement of the hip or shoulder or other peripheral joints. So sometimes people may confuse with the arthritic changes and other things. Just to rule out those components, we need to have X-ray investigation for peripheral joints also. So in the beginning part of the disease process, like just say in the adolescent and the young adult, this may not be necessary. But when it enters to the adulthood or later part of the disease, screening of the peripheral joints in terms of diagnostic process is very much necessary. The condition based on the Indian database, the condition it's very misdiagnosed many times, and the actual time for diagnosis in India, it took almost 8 years, maybe because of many reasons, because the complaint are related to the low back pain. So people may focus only on the low back pain and its management without consulting or without suspecting on the probable AS diagnosis. So, and negligence, I would say that they will, in the beginning part of the disease process, the features will come and go. And that may be another reason for delaying the diagnosis. So on an average in India, it took around 8 years to come to the proper diagnosis of this condition. So if you already have a suspicious, considering the above features, one should not wait for longer duration to actually start the diagnostic process. Differential diagnosis is something what we require because this particular condition affects with a different age category, ranging from the adolescent, adult, and adulthood. So we have many other rheumatoid conditions are there, or else spondyloarthropathic conditions are there. So some of them are having similar features, so we need to go through the differential diagnosis. So at the first point, we should look for other type of spondyloarthropathy. So just as an example, psoriatic arthritis we should look for. And this is just not limited to the psoriatic arthritis. This is just one example. Other type of arthritis like RA, some of them might be in the continuation of JRA or starting of adulthood RA. So this also once again need to be ruled out. And just for information, RA is a seropositive condition, and the condition what we are discussing is seronegative. So again, many factors we need to consider just to exclude or include this other arthritic form. Then we also look for other causes of back pain. So many other causes of back pains are there, like simple spread pain and fibromyalgia. Those also should be ruled out. Then other cause of sacroiliitis. So septic sacroiliitis is one of the common, which can be seen in any age group. So these are few examples. So we have to go through the diagnostic, differential diagnostic procedure so that we can exclude the other condition and finally come to our proper diagnosis. Coming to the prognosis in the long term undiagnosed, or you can say that a neglected condition. Now here I put link with the things which are happening in India. We have already evident that we are already in the late diagnosis is what is reported in India, right? So it could be something you can consider as a long-term undiagnosed. So most of the population which we see in the India with the age, when you get to diagnose in the proper age, maybe around 30s or early 40s, they might already have osteopenia or osteoporosis. And this may easily lead to compression fractures, or even the humpback can be easily developed to this kind of people. Typical sign of progress is, like I said in the beginning, situation which is find are not seen. Anytime you can find development of syndesmophyte on X-rays, you can already get evidence that the condition is progressing. It is not stable, or it is not reversing. It is just progressing. So that is also should be keeping in mind. In a fusion of vertebra, sometimes because of entrapment of the nerve roots, especially in the lumbar or lumbosacral region, paresthesia can be seen based on the nerve root involvement. It may be bilateral or unilateral. This may be due to the inflammation of nerves surrounding to the area. So the person who gets early diagnosis would be able to get a better counter from the disease progression. But based on our database, we have late diagnosis. When we come to the patient, when we try to encounter the patient and we try to gather the features of the patient at the clinical level, we have different disease-specific instruments. And all of these are supposed to use at the time together, not separately using. So we have outcome measures related to the disease activity and related to the functional limitation, related to the spinal mobility, and related to the radiological change in the gradings, right? So for this activity related, we have a BUS-DI and a BUS-FEE for functional index, and spinal mobility we have BUS-ME. Then for a radiological we have BUS-FEE. So the last one, modified stroke, is spine score. We can skip this one, but if you are using BUS-FEE, that should be good enough to document the change in radiological grading. So this is some template of those outcome measures. Anyone can Google it, and it is freely available online. It is recommended, highly recommended to use all conditions outcome measures when you already confirm the person who is diagnosed with that. Yeah. Now, moving on to the next part of the presentation. Management, it is a multi-disciplinary approach is needed. It is not a task which could be conducted only by the physios or only by the physicians or rheumatologists or surgeons. It requires multiple professionals comes together to manage this condition. As you can see in the flow, this image, Patient education, exercise, physical therapy, rehabilitation, and the self-help groups organizing among the same diagnosed people become a lifetime requirement, full-time requirement. So we physios should be very proud that we are taking a very long-term role in handling or managing this condition. Uh, it could be physician or it could be rheumatologist who will deal with a prescription of the medications, some forms of medications which I have already listed here, NSIDs, analgesics, then DMARDs, and the local steroids, TNF blockers. So the below drugs in the blue colors and the black colors are already in the trial and they've shown some positive effects. But more or less, these are the tasks which are going to be done by the physicians or rheumatologists. But by knowing this class of drugs, so we would be able to better convey the message to our patients. So if they have not consulted to any of those professionals like physicians or rheumatologists, we should always provide reference service to those professions so that the patient should get relevant and suitable medication so that it will be helping in countering the disease process. And as and when required, surgeon can involve, just say because of osteoporosis, spinal fracture comes in, or else any fracture or any nerve problem involved. So that time surgeon may intervene. So surgeon, mostly the spine surgeons may be taking part in this area. Okay. So like I said, this is not a role of management of AS, it's not a role of single professional. It requires multi-professional. But yeah, I would not be elaborating much on the other aspect, but let me try to elaborate a little bit more on the role of physiotherapy, which is our good for today. So, yeah. Before we enter to the actual management, let me just summarize the available evidence on evidence of physiotherapy about this condition. We have a number of level 1 evidence for the effectiveness of physiotherapy in this condition. However, the effectiveness of long-term effectiveness studies are lacking. So our team from the RAF, we have taken effort to study a long-term, but as the condition is little bit lesser in the incidence or numbers, we could do only the single case study. So in that, we have given intervention for 4 weeks and follow-up taken after 6 months and even for 1 year. So that is how we have tried to check the long-term effectiveness, and we could see that some positive long-term effectiveness were found in our study. But still, I recommend that some more studies are required to prove or to substantial the actual long-term benefit of physiotherapy in this condition. Some literature advise that the patient will require exercise for their lifelong. So this may be on and off. They might continue exercise for 2 to 3 months and may take off for another, maybe just 1 month or 2. Then again, they have to continue. So this exercise has to be a new lifestyle for them. This is what evidence suggests. And it is also suggested that taking warm bath before the exercise tends to reduce their discomfort and making more easier or more comfortable to start exercise. And it is preferable to choose a particular day for exercising. So if you are having patients in OPD, don't call them in a random time in the day. So just fix particular timing for them because their features are slightly likely to change when they have change in the different times in the day. Like I said, in the early morning, they tend to be slightly stiffer compared to the mid part of the day. So if you're calling them for exercise in your clinic or in a hospital, try to fix a particular time for them so that the output or their issues can be understood in the constant. Some of the common this is not limited and all of them may not be required for all the individuals who diagnose the disease, but the things which is very much common for required for all of them is to educate them. Okay, next one is to relieve their pain and spasm, maintain and improve their mobility of the spine and peripheral joints. The peripheral joints are involved, and to strengthen the muscles around the trunk, legs, back, and abdominal, and to minimize the deformity because deformities are also going to be progressive, and to regain their fitness. Like I have mentioned, they prefer to be more excuse me, spectacle rather than actively involving it. So it tends to reduce the overall fitness. So one of our aim has to be towards the regain or maintaining or boosting of their fitness, and to relax the body. So when multiple group of muscles get spasm at a time together, they get more tense. So we should plan something to relax their body as a whole. And finally, our aims should be towards the improvement of their functioning overall together. For patient education, like I said, we are giving patient education to many of our cases what we are dealing now. It become a very crucial role in our successful management. The education should contain about the possible progression of clinical characteristics. So I will keep on mentioning that in the beginning, in the mid, and the later part, how they are progressing, that need to be thoroughly explained to them so that they can actively understand how they are going to change themselves and how their features are going to change. This information they need to be aware. And prognosis, I have already discussed some of the possible prognosis. So this also need to be mentioned or included in our education content. And what are the available treatment options? And who are the professionals who will be involved, who can involve in solving or in management of this condition? All this information need to be included. And if they are smokers, then we need to convince them. We need to include in our patient education to stop smoking. Okay, so this is new content, minimum content we could include in our content of patient education. Based on their requirement, we can keep on increasing our content, but this is the one which minimum we should include. Relief pain and muscle spasm. What therapy has been shown as an effective, particularly applied in the affected area, just in the side area or lumbar area only, then we can think of applying only to the locality. But as I mentioned in the latter part of the disease, when the multiple segments or multiple joints are affected, or else the sonarbars could be another replacement because we may not be, it may not be feasible to apply multiple moist pack at a time together. So alternative options can be looked into. And having a lukewarm swimming pool, that could be another alternative. So this is again may not be feasible in Indian context, but in the Western they have already have this provision. All relaxed techniques, specifically you can say that the muscle energy technique could be another easy way or easy and beneficial for reducing muscle spasm. This can be again for those who are convenient or easier to do with a traditional stretching, that is also fine. But anything with benefit in relaxing the muscle or reducing the muscle spasm, they are always beneficial. So to name some, passive stretching, muscle energy technique, and some literature also has tried to bring up some evidence of the MFR. I really don't endorse MFR, but I would like to endorse the MET and the stretch. Hydrotherapy, we already know that it's giving multiple benefits to our system. So it also helps in minimize the pain and spasm and restore the mobility of joints. And moreover, apart from that, they also give chances or give scope for improving or maintaining the cardiovascular system, which is reducing this group of people. So all form of exercise, they have to do exercise at least 30 minutes per day, and it has to maintain at least 5 days in a week. If they're able to do every day well and good, but minimum they have to do 5 days in a week. This is a minimum dose that they need to maintain. Final extension exercise along with the breathing exercise. So as they are going to gradually now coming towards the flexion position to counter the deformity, the extensor or mobility towards the extension equipment. And we already come to know that the chest expansion is limiting and it is going to affect the respiration or exchange of the air. So breathing exercise also becoming a key part of the exercise in this group of people. So final extension exercise in the prone line alone can be done in the beginning and separately for breathing exercises. And when they are mastered in the extension exercises, they can club together extension plus chest expansion. They can synchronize together along with the breathing. So that will cut short the time also, and that will be more convenient for them also. But for a beginner, it may not be suitable. But for the people who are doing exercise for longer duration, they should be able to mix up or combine together. So the dose of exercises should be mild to moderate doses only. It should not be towards the high doses. Always it should be mild to moderate. In any position, they should advise to hold for 5 seconds and relax and repeat the exercise about 20 times in the session. So similar session can be 3 to 4 sessions can be repeated in a day based on their convenience. Strengthening and stretching exercise. The objective of these two exercises are to prevent stiffness and to regain muscle strength and muscle wasting and weakness. So again, the primary muscle required muscles are back extensors and hip musculations. And based on the requirement, the numbers of muscles and group of muscles requirement will be keep increasing. But if I have to talk the minimum muscles, then these are the two groups of muscles we have to focus for stretching as well as strengthening. And with these exercises, we try to achieve at least functional range of motion of hip and shoulder joint, because we believe that these are the two joints which are going to affect in the latter part of the disease. So in the beginning phase, we should try to maintain the mobility of these two joints so that it should not be restricting factors for their day-to-day activities. Daily stretching of involved joints improves joint mobility. So from the other literature also, we already got support that stretching always benefiting of joint mobility. So stretching of the involved muscles, here I am not able to list out everything because as the stages of progress, the number of and group of muscles involved is going to be keep dynamic. So I have only mentioned the minimum muscles, but as per requirement that the targeted muscle has to be based on their body. Some of the sample exercises I'm showing up here. These are very easy way of doing it, and anyone can perform wherever they are, maybe in the workplace or at the home or any place. Okay, it may not be very high intensity, or it should be very easy to do it, and it should not be pressurized to do it. So bridging exercise, camel exercise was always loosen the spinal or lumbosacral region. Rotational exercise for lumbar and cervical region, then side bending exercise sitting in a chair, and shoulder mobility exercise and stretching of the hamstring and hip flexors. So these are some simple sample exercises based on your requirement. You can keep on modifying, but at least this can be taught to them so that they can perform at home without any requirement of equipment or something. Group exercise is also shown to be beneficial in this group, particularly to motivate them. We are always aware about what are the benefits of group exercise. So group exercise, if the clinic or hospital has got a sufficient number of patients with the same diagnosis, to cut down or to save the time for yourself and the patient, you can organize a group exercise session. And it will be keep motivating one another and encourage to adhere in the exercise also. So group exercise could be in a different platform using the gym equipment or using the swimming pool or in other different possible way. So having one group exercise session in the setup where you have more number of patients would be another advantage in management of this condition. For people who are living with the condition, they might be beneficial from some of the device which will reduce functional limitation for them. Again, this again completely depend upon the stages of disease. Everyone may not be requiring this, but if they require, we can choose any one of these and improve their functioning. So cane will be used for working, and a special chair or desk can be one of the helping hand for them. And special shoes because they have difficulty bending forward. So tying lots of knots or steps could be again difficult for them. So device, we have some devices or simple devices which assist in putting on the socks or shoes can be a simpler one to make them improve their function or reduce their limitation in their simpler one can be. These are some tips we can always give to your patient. And again, this is not limited and based on the endorsement level, the requirement will be keep changing. We all know that they have already having high risk of osteoporosis. So avoiding fall become another key component. This may not be directly related to the management of condition, but secondary to the condition, once any of this population get fall, they will get itchy infection that will again complicate in the management. So always wear a good pair of skid resistant shoes, especially when they are uh, nearby to the washroom or any slippery surface, okay, or using the toilet or near to the swimming pool. So again, anti-skid shoes are always advisable for that. Some modification to prevent fall, like having a rail or bar, grab bar in and around a shower or toilet, or having a shower sits or rising sits, rather than having a Indian pattern. So these are some modification and well lighting in and around the house or in and around the common access point. That could be again some help to them to avoid fall. Posture has to be maintained in a different situation, not only in the resting, in the dynamic situation and in the occupational situation also posture has to be maintained. Resting posture, like especially in the sleep or in the resting position, they should sleep on the firm bed, not on the saggy or water bed, which is not firm, which should not support their spine. Preferably make a habit of sleeping on the prone positions. This will help them to counter the deformity. And pillows should be avoided under the knee because when the spine goes for flexion, eventually the heel and knee gradually develop flexion deformity. Again, having pillows under the knee or habit of putting pillow under the knee may eventually develop softness or tightness of the hip flexors and hamstring muscles and force them to develop another deformities around the knee joints also. It's better to avoid that. And they will be having forward head neck posture also. So some of them may not be comfortable with a thin pillow and they may prefer to go with a 2 or 3 pillows. So always encourage them to use the pillows which is sufficient to support the head, not in the excessive manner. So reducing the pillow numbers or putting only the minimum requirement is what they should practice whenever they are in the beds. Dynamic whenever they are in the movement, maintain upright posture in walking or in any dynamic situation. Avoid any tendency to stoop forward. So this is again very likely to happen because they get tired very quickly. So whenever they exposed to any prolonged activity which involves in a dynamic situation, they tend to come into stoop position. So they should keep remind or they have to be alert that whenever I'm in the stoop position, I need to be upright. I need to come out from that position. Some people might think of advising for sling, braces, or corset, but in this case, based on the literature, this additional supportive devices are not advisable. In the occupation, we need to analyze their habit in the workplace and the posture, how they are assuming in their workplace, and if needed, possible or necessary modification, we need to do it so that they don't encourage the deformities. Avoid prolonged activity in the stress posture. like they will be having difficulty in maintaining any sustained or prolonged position. So we have to identify and advise them to avoid those prolonged maintaining any prolonged position in the stress situation. Take sufficient break between sitting and standing posture. So easy way could be every 30 minutes, 35 minutes, they could change the position for a few minutes and come back and resume the position, just to break the sustainability of the one particular position. If they are working the break time or in the lunch time, recess time, they can take a break, and this particular timing, they can utilize to maintain themselves into prone position, which is countering the difficulty. And they can also involve in deep breathing exercises frequently during the days. Okay, these are a few tips we need to taught them, and they need to practice in the resting, dynamic, and occupational posture. The group of people are again ranging from the young, so many of them might be involving in the sporting activity or recreational activity. So not all games are beneficial to them. So activity that encourage spinal extension and rotations are recommended. So just for example, walking, then hiking, then swimming, tennis, badminton, cross skating. Okay, these are some of the form of exercise which encourage spinal extension and rotation. That should be always recommended. Volleyball and basketballs are very good because they tend to give a good fitness level. But however, everyone may not be able to tolerate these two games because the intensity of games are a little bit higher than the other games. Activities that require prolonged spinal flexion are not recommended, such as playing golf, then bowlers, just cricket bowlers, or else long distance cycling where they need to lean forward and cycle. So anything which force them to remain into prolonged spinal position, that will again encourage a question mark deformity or flexion deformity. So those are not recommended. Contact sports are also not recommended because they have potential to injury, and these people are already having weakness in their bones, so they may get easy fractures or easy injuries. So sports like boxing, rugby, soccer is American term, or we can say football, or American football, hockey, or downhill skiing. So this all comes under the contact sports. So these are not recommended in any group of this diagnosed group of people, because they have potential of injuries. Yeah. These are some well-known individuals who have already diagnosed with the Ankylosing spondylitis, and they have lived their life with a success, even though they have this diagnosis. So my last message is that our patient should not be worried or afraid that once I'm diagnosed with this condition, my ADL or my functioning are going to be restricted and my lifestyles are going to be compromised. No, they can still live a good functioning life even though they are diagnosed with this condition. And these are the references which are used to prepare this content. The reference number 7 is the main references which I have used. Most of my contents I have taken from this reference. Thanks for listening. If anyone has any query, you can ask. Thank you.
Thank you, sir, for this session. We do have few of the questions from the participants who are attending this session. I'll tell you each of the question and you can try to address them. The first question is there any diet that is specifically for AS patients which can be helpful for them?
Literature does not face any involvement or any contribution from the dietary aspect. But if you are considering the probability of developing or getting osteoporosis, so a diet which can complement or counter the osteoporosis can be beneficial as a supplement, but it will not help in resolving or reversing the condition.
Right. Fine. Thank you. The next question is is massage or chiropractic therapy or acupuncture, are any of this safe for AS patients?
Yeah, I don't want to advocate for other professions like chiropractic and other, but I would like to advocate a little bit for a massage. Massage is generally used for relaxing the body part or the body structure. So, like I already mentioned, one of our aim is to relax the body. So, having massage to the affected area will be always beneficial, but I will not be able to comment on the effectiveness of chiropractic and other naturopathy.
Or acupuncture. Right. One more question is, if the patient has GIT infection, so is it so that they are at more risk of getting an AS?
Yes. I'd like to share one of my experience in one of my patients. Uh, the one which I have presented, I have reported in the single case. When we take his history, he reported that in his early 20s, he used to have frequent diarrhea, maybe just twice or 3 to 4 times in a year. And with the help of medication, it resolved. But it goes on for another 4 or 5 years. So he was diagnosed as a diarrhea, and physicians and other attending professionals, they have treated him only for diarrhea. But nobody suspected him that he could be a potential diagnosis for it. And meanwhile, along with the diarrhea, he also had frequent back pain. Once he had been admitted to hospital for 2 weeks because of sciatica and back pain. So in that particular time, that was somewhere in his 20s. In that time also, people diagnosed him as a sciatica only, but not focused or not identified as a AS condition. So when we start narrating this one, I mean, collecting history from him, and the literature also says that, literature also says that the reason why GIT infection, frequent infections are leading to development of this condition still debatable. It's not conclusive yet, but most of the patients, they have such history. So if anyone who have a frequent GIT irritations or diarrhea or infection and mixing up with the low back pain, specifically in the lower lumbar or SI region, so they should not be excluded from suspicious of AS condition.
Right. Thank you. One more question. I guess the last one is that in AS, the muscles are affected in ascending pattern. So is there any chance that the muscles can also be affected in descending pattern?
Muscles, I would say that rather than ascending or descending, based on the area of involvement. I have seen some patients, only SI and lumbar region affected, and suddenly jumping the remaining part of the spine and start affecting the shoulder joint. So this pattern also could be changed to some extent, but most of the time they follow the similar pattern. SI would be the starting point, extending to the lumbar, thoracic, and eventually to the cervical, and finally to the peripheral joints. So based on the area affected, the muscle involvement pattern also will keep changing. So it is, yeah.
Okay. Thank you, sir.
Excuse me, ma'am. There is one question on YouTube channel as well. One of the participants is asking about the prone line, like sir has mentioned in the slides, that prone line is advisable. So the question from the participant is, patient experiences discomfort on a sleep on stomach. So why there is a sleeping on prone is advisable?
Yeah, very nice question. Prone line was encouraged and recommended just to counter the deformity. So in the beginning, they will have discomfort. Based on my experience, in a few days of the beginning practice, they won't be able to maintain more than a few seconds. So that's 30 seconds, 40 seconds, that would be the time limit they will be able to sustain. But they can break the pattern, so they may maintain for 30 seconds and come out in the sideline or so far. Again, resuming the prone line. So this way, gradually we can lengthen the duration of prone line. And the requirement for prone line is because it is straight away countering the deformity. Rather than have multiple stress of multiple joints, just simply lie on the prone position can easily counter or it can help in countering the deformity. So that's why lying on the prone, even though it becomes difficult for them, it becomes a key exercise in this group of people. I think I have answered that question.
Yes. So I guess no more questions, right? Okay. Fine. So we'll move to the vote of thanks. So on behalf of IAP Women's Cell Kheda District, I would like to take this opportunity to extend my gratitude to Dr. Ratan Kuman, our esteemed resource person, for their invaluable contribution to the webinar. Thank you for improving our understanding on ankylosing spondylitis and its role, like the crucial role of physiotherapy in its management. I would like to thank my teammates, Heta Madam and Vaibhavi, for their contributions and their support in conducting this entire event. I'm also thankful to our mentors, Dr. Shweta Parikh, Central Zone Head, Dr. Bhavna Gadwi, State Head, Dr. Pooja Kamble, Zonal Head, Dr. Ruchi Vaishnav, Women's Cell Head, Dr. Sanjeev Jha, President of IAP. Their dedication to inclusively added to this webinar success. Dr. Uttara Mohan and her dedicated technician team for their ensured flawless execution. I also thank the participants who has actively joined and asked the questions and showed their active participation during the session. Yeah, so I guess that's it. Thank you everyone for joining us. And I hope this has been a fruitful session.
Thank you, everyone.
Thank you,
Thank
sir.
you.
And participants can subscribe our channel, IAP India.
All right. Thank you, everyone.